presentation, Is There a Doctor on Board? Using Health Impact Assessment in Transportation. Anna Ricklin is a recent graduate of the Bloomberg School of Public Health, where she received a master's in health sciences. Before coming to Hopkins, Anna lived and worked in Portland, Oregon, where she saw how a truly multimodal transportation system benefits the health of an entire community. Her studies during the past 2 years focused on the built environment and health, with a particular focus on how transportation infrastructure influences behavior. She has recently been hired by the Baltimore City Department of Transportation as their first full-time health expert and plans to work closely with the health department and other agencies to promote active living throughout the city. Clifford Mitchell is the director of the Environmental Health Coordination Program and the Preventive Medicine/Public Health Residency Program at the Maryland Department of Health and Mental Hygiene. He joined DHMH in 2006. Prior to that, he was on the faculty of the Johns Hopkins Bloomberg School of Public Health for 14 years. He is trained in occupational and environmental medicine and internal medicine, and his research and practice both focus on workforce training and indoor environmental issues, as well as preparedness. With that, I'll hand it over to our presenters.
Good afternoon. So the objectives of the talk today are to talk about what health impact assessment is, and then I'm going to present a case study of a health impact assessment that I worked on the Baltimore Red Line project. And then Cliff is going to discuss the public health impact of transportation choices and the role of health in transportation planning. So health impact assessment is a tool. It's a set of methodologies that assesses proposed policies and projects. It's a prospective process that looks at what the potential impacts will be of a policy or a project or even a program, what the impact will be on communities. And that identifies communities, which communities will be affected by the project, and then also looks at if the impacts are going to be positive or negative, and then what the magnitude will be, if that will be a big impact or neutral or a small impact. Some of the methods include interviews, data analysis, talking to experts, and looking at scientific evidence. It's often a collaborative effort among agencies and different stakeholder groups. So it's not usually just the health department undertaking this process. And in the case of the Baltimore Red Line, myself, I worked at the Baltimore City Department of Transportation, and I worked with partners at the health department to do the Red Line health impact assessment. So just to orient you to the Red Line, it's a 14-mile dedicated new transit line that has not been built yet. And it will run from western Baltimore County to the eastern edge of Baltimore City. And it will connect with, we hope, the 2 current rail lines that exist. And it will also connect to major employment centers. On the western side, it will connect with the Social Security Administration, and on the eastern side, it will terminate at Johns Hopkins Bayview Hospital, and both of which have thousands of people per day that go to those places, as well as the line running straight through downtown Baltimore. So I just wanted to talk about some of the context for doing the health impact assessment. It's kind of a unique situation in Baltimore. The impetus for undertaking the HIA was the Red Line Community Compact, and it's a new kind of community benefits agreement that was initiated by the mayor of the city of Baltimore in spring of 2008. And it's a collaborative agreement among different stakeholder groups involving the city, the state, nonprofits, private entities, as well as community groups being kind of the keystone for the process. It sets specific goals and strategies for the project to see what everyone has defined as success for the project. So not just putting in a transit line and being able to ride from point A to point B, but actually looking at the Red Line as an entire way to grow communities, revitalize neighborhoods along the route. And it was signed in the fall by more than 60 groups. So a lot of people are on board with the Community Compact. It covers 4 topic areas, which were decided upon in an iterative process with many groups in putting their input into it. And of course, putting Baltimore to work on the Red Line, looking at economic development along the route. Community-centered station design is looking at transit-oriented development and community revitalization around stations as a way to encourage more businesses and more communities. And then aggressively planning and managing construction is a huge part of it as well, because construction will be the face of the project for 3 to 5 years. And then the section that took on the health impact assessment was entitled Making the Red Line Green, and it's looking at what are the health impacts and the environmental impacts, looking at water quality, alternative energy, and green space as well. So the methods for doing a health impact assessment, these are the 6 basic methods that you'll see in the literature are talked about as sort of the basic steps of doing an HIA. And the first one is screening. In the screening process, you sort of look at the project and you decide if a health impact assessment is appropriate. You look at the different aspects of the policy or the program and see if a health impact assessment would actually produce viable recommendations. And in the case of the Baltimore Red Line, we decided it would be a good idea. Scoping talks about what are the issues that we'll focus on. There's so many issues that we could talk about with the Red Line. There's so many issues we could talk about with any project, but what are the ones that we're going to focus on for this HIA? And I'll go into what we did end up choosing in a moment. Assessment looks at the magnitude and the direction of the impacts that I spoke about earlier. It really is looking at which components and which neighborhoods will be affected in what way. Recommendations are the point of doing an HIA, really. I mean, we can do an assessment and we can say that there will be these or that health impacts, but to take away some concrete recommendations about how to maximize health is sort of the point of doing the HIA in the first place. And then reporting and evaluation are ways to give feedback to the communities that are involved and then evaluate to see if the HIA had any effect on how decisions were made. And for the Red Line, we're still, because we completed it in last fall, in December of 2008, we're still sort of seeing what the fallout will be and if the recommendations are taken into account as the process moves forward. I just wanted to show some data from the Red Line corridor. So this graph is oriented west to east as if you're looking at a map. And for this graph, it shows life expectancy along the corridor. And you can see that there's very variable life expectancy along the route, starting with medium high life expectancy in the far western part of the city and dropping down significantly as you go into the middle of the city and then going back up again as you go to the outer eastern parts of the city. And the same with the next graph that I have here, which shows the percentage of households who don't have a car or access to a car in their home. Again, it shows a highly variable rate of car ownership and car access, which is, as we might be able to guess, a proxy for socioeconomic status in those households, as well as an indication of how those people are able to get around and what their transportation options are. You can see that the higher numbers kind of parallel, the households with the higher percentage without a car kind of parallels the previous slide, which showed lower life expectancy in those same areas. The findings of the HIA overall from our screening and scoping process and the initial assessment, we decided that the Red Line will probably overall have a positive impact on health. We can see that it could provide economic development opportunities, community revitalization, and many options for people to giving people more options to get places will probably positively impact their health. The question is, of course, to take it further and say, how can we maximize health with this project? Again, we don't want to just put in a rail line or a bus line and say, okay, well, we're improving health by putting in this new transit. What can we do to actually maximize it? So the 3 issues that came up out of our scoping process as the main focus were improving access to transportation and making streets safer, improving air quality, which is sort of by default, if you take more cars off the road and diesel buses off the road as well if you're replacing it with a new rail line. And then mitigating construction issues, because those are going to be the initial part of the project, and it's a significant issue for many residents along the route. So the first issue was improving access. And Healthy People 2010, I just wanted to remind us all that states that the broad physical and social environment, which includes housing, urban development, and transportation, shape human health. So the federal government has said the outside environment is shaping our health. Transportation is one component of that. And the red line, as we saw it, could impact 4 major issues, one of them being neighborhood cohesion, how much people connect with their neighbors, how much people connect with their families. Access to green space, which is partially healthful just because it provides relief from depression and anxiety in neighborhoods. It can provide areas for physical activity. And then access to services also is an important part of access. People being able to get to health care, people being able to access healthy foods, grocery stores, that kind of thing. Promoting physical activity. Currently, in the state of Maryland, about 50% of the population, possibly even more, doesn't get the recommended amount of physical activity. And the cost of that is really high because in Baltimore City, at least, we have about 35% of the population is obese. And that's much more prevalent among African Americans than it is among white adults. And it's also risen 50% over the past 10 years. So it's a significant problem in the city. And it's been shown, some evidence has shown that actually walking and biking to public transit can increase your access to physical activity, the amount you get per week. So that would be a good improvement for many neighborhoods along the route. In terms of safety, we have a disproportionate number of crashes involving pedestrians and cyclists in Baltimore. About a third of crashes involving pedestrians in the state of Maryland occur inside of Baltimore City, and about a quarter of crashes involving cyclists occur in Baltimore City, even though we only have about 6% of the vehicle miles traveled in the state of Maryland. So we have, part of it, of course, is behavior of cyclists and pedestrians, but also a significant part of it is the infrastructure that people are walking in and biking in the city. And evidence from Europe and other US cities that have a lot more supportive bicycle and pedestrian infrastructure has shown that there's less of a risk of crashes when that is present and when people are using that, partly because those users are more visible to drivers in particular. Improving air quality, we all know that toxic pollutants from emissions affect our health, especially for the young and old, and that these can be long-term health issues. But it's also important to think about the proximity to high-trafficked areas. So much of the red line is along major roads. If you live in Baltimore, you're familiar with Edmondson Avenue, Boston Street. These are highly trafficked roads that probably people along those routes who live there because they're residential areas have a greater exposure to vehicle emissions than people who live further away from major roads. And so if we can decrease traffic on those roads, we can improve the local air quality for those people. When it comes to construction, we're also looking at dust and emissions from construction equipment that affect air quality, looking at demolition, effects from concrete dust, and noise, of course, is going to increase stress, disturb sleep and concentration for children in schools and people working in office buildings or wherever they're working along the route. So any way that we can mitigate those two things would really help improve health. And then rodents. The issue of rats was an interesting one. When I spoke with community people, when I did interviews with residents, and also listened in on different conversations that people were having about the red line, a lot of people spoke about the rodent issue. So it's extremely important for residents. And I did a little bit of research. There's not a lot of data actually on rats and rodents in particular at construction sites, but it was seen that they were more visible around there, and certainly the potential to spread disease and just have an unsightly effect in neighborhoods is significant. So when we come to recommendations, one of our sort of overarching recommendations was to maintain community involvement in the process throughout building the red line. And then to make it light rail, we think that light rail has many more benefits for the city than putting in another bus line. And also to include a public health expert in the planning process. So with the state agency who will be building the Red Line, in city meetings, making decisions about development projects and the like, we think that having a public health expert or multiple experts involved would really help improve the health and the outcomes for how the Red Line is designed in the end. And then another overarching thing that we wanted to see is more green space along the route, more trees, more preservation of open space. I have this map that was made by Parks and People Foundation, which is a nonprofit agency, excuse me, here in Baltimore. And they show that in the middle of the city, there's a significant tree deficit area. There's parks along the edges. See if I can use the pointer here. No. There's parks along the edges and green space along the edges we can see, but in the middle, exactly where the Red Line will go, it is very, very open, and there's not a lot of shade, and there's probably worse air quality than where there's more trees. And so the Red Line, which will cut straight across east-west through that area, through construction, through the building and the design process, we have an opportunity to green a part of the city through the project that we wouldn't have otherwise. So we're trying to encourage the designers and the builders of the project to add an extra component to it as they go. Recommendations for accessibility. One of them is to absolutely ensure connection between the current rail lines. So the plans sort of amorphously refer to transfers between the current light rail and the current underground metro line in the city, but we want to make sure that that's actually going to be the case. Number 2, coordinate with the Baltimore City Bicycle Master Plan, which already exists, to ensure connectivity for cyclists and pedestrians as well, because pedestrians benefit from cycling infrastructure also. And then to use complete streets design when you're looking at sidewalk widths, accessibility for people with disabilities needs to be absolutely included. And then plan for numerous crosswalks. So if there is a train line down the middle, the median of a street, for example, that there is a lot of connectivity between both sides of the street, which will help maintain some of the neighborhood cohesion I was talking about earlier. For the construction aspect, provide independent monitoring during the construction phase. So don't just count on the construction contractors or the state agencies to make sure that the health and safety of people along the route is ensured. So to actually have an independent group looking at that, and an independent group that potentially residents can report to. This was something that was also mentioned in the community compact, but we wanted to reiterate it here as a component of health. And then the EPA has actually outlined some clean construction models for contractors to use when doing a big project like this, to have the most modern and up-to-date vehicles with ultra-low sulfur fuels, and then also looking at the care of construction sites. So if you have open ground, to make sure that it's not a lot of dust, creating a lot of dust in neighborhoods. Noise mitigation, as I talked about before, there's different methods for that. And then planning for rodent control. And this is really important to start now, as soon as possible, and do surveys and involve the community in the process, because it's not just about the construction company making sure that they control for rodents, but actually the entire community being involved in reducing trash and that sort of thing. And that concludes my section. This has been the case study of the Red Line Health Impact Assessment, and now I'm going to pass it on to Cliff to talk about the bigger picture.
Thank you, Anna. It's a pleasure to be here today, back at the Bloomberg School of Public Health. And before I start off, there are a couple of caveats to give to my comments. One is that I already received several emails from nurses and other public health practitioners pointing out that it's not a question of whether there's a doctor on board, it's a question of whether there's a health professional on board. And I just want to acknowledge for the record that it is very important to cover that this is a process that involves many disciplines, physicians, nurses, industrial hygienists, and public health practitioners in general. The other thing to say is that Hopkins has a long association with health impact assessment, and it's important to point out that tradition. Dr. Andrew Dannenberg, who was formerly of the faculty here and whose father Art is in the audience today, is probably the country's leading exponent and proponent for health impact statements, and is working at the CDC in the National Center for Environmental Health, and has been instrumental in advancing the field, both the field of health impact assessment and the practice. And there are several people on the faculty here whose work has made important contributions to our understanding of things like neighborhood effects on health. So Dr. Brian Schwartz, and the work that he's done in the Baltimore Memory Study with Tom Glass, looking at neighborhood effects on things like cardiovascular mortality, have in fact played an important kind of informing for the idea of linking geographic boundaries and geography and place and neighborhood to the idea of health impact. So I think it's important to think that think about the link between research in terms of public health research and the practice of health impact assessment, because this is a field that actually really cries out for a larger research agenda as well as a practice agenda. So with that kind of framing, let me just talk a little bit about the issue of built environment and health. In the old days meaning before we did health impact assessments, and in fact before the sort of modern public health discipline was prevalent, we looked at place and we thought about place, and particularly things like urban design, mainly from the point of view of sanitation and control of communicable diseases, because those were the things that killed people. And so things like urban density very closely linked to the spread of infectious disease, as well as issues related to sanitation and issues of hygiene and environmental hygiene. Now, having made significant advances in terms of hygiene and communicable disease, our more modern concept of urban design and the built environment has really sort of shifted from issues of communicable disease transmission to issues of chronic disease and the effect of the environment writ large on things like chronic environmental exposures, physical activity and the built environment, and other kinds of environmental influences. This is not to say that we've solved the problem of communicable disease, as those of you who are dealing with H1N1 can attest, but it is true that we have a sort of a larger view now of the relationship between the built environment and public health. So, as one aspect of the built environment, and a very important one I might add, is the issue of transportation. There are other issues having to do with how we build cities, urban design, etc., but transportation has played an important role because, particularly because of the way we do transportation. Transportation is a significant contributor to air pollution and to lifestyle and behavior, and those issues have played very significant and growing, we have a growing awareness of the relationship between things like air pollution and physical activity, obesity, cardiorespiratory disease. Now, for many, many years we've been looking, and this is not new actually, if you think about the 6 city studies and our sort of historic view of air pollution, we have looked for a long time at issues related to, since the 70s and the 80s, at issues related to photochemical smog, particulates, and heart disease, asthma, other lung disease, mortality, and morbidity. In general, those early studies tended to be and to focus on population effects, and they looked at very large populations, usually in multiple cities, involving many, many tens of thousands or hundreds of thousands of lives. And part of the reason for that was that we were thinking about basic epidemiology and mechanisms of disease. Part of the other reason was that we really didn't have a lot of tools or understanding of the relationship between individual exposure and disease. This was really sort of aggregate exposure and aggregate disease. So Dockery's work on Pope and Dockery and the 6 city studies, we were looking at very large populations, and we were not looking at individual dose, we were not looking at individual exposure, we were looking at tens or hundreds of thousands of people over long periods of time, and didn't think too much and didn't have the tools really to look at individual exposure. As we've refined both our methodology and our understanding of basic mechanism of disease, we've started to look in more detail at the relationship between geography and place and exposure and disease. And we've started also to broaden the category of outcomes that we have been interested in. So we're now focusing more attention on a more direct understanding, a more direct relationship between individual risk, individual exposure, individual vulnerability, and particularly the presence of vulnerable populations such as children, the elderly, people with asthma, people with other heart and lung ailments or other diseases. And we are trying to get a better understanding of not just aggregate effects, but individual vulnerability or group vulnerability and susceptibility. This is important because as we think about moving from both a regulatory regime and a sort of a public health prevention regime that focuses on large issues like reducing the entire ambient airshed concentration of photochemical smog or ozone or PM 2.5, particulate matter less than 2.5 microns, down to a more sophisticated view of design and planning, that really requires a more granular, a finer understanding of the relationship between an individual location, individual sources of pollution or of hazard, and individual vulnerability. And it's that kind of focus on sort of ground level, granular detail that's necessary if you think about things like master plans or design of something like a red line or a large-scale development or small-scale urban development or where you're going to place even an individual factory. So, for example, if you think about issues such as facility siting or facility permitting, if we are going to have the wherewithal to look at whether or not it's a smart idea to locate a facility that is an emitter of volatile organic compounds or dust or asphalt, volatile organic compounds from asphalt manufacture, and if we're going to have the ability and the wherewithal to say, is it a good idea to site a particular facility in a particular location, you can't really answer that question by simply looking at the airshed particulate load or the airshed ozone concentration or the city's overall mortality related to asthma and cardiorespiratory disease, because that doesn't help you with an individual siting decision like that. Instead, you really have to think about, well, okay, if I take this factory and I put it here, what do I know about the surrounding neighborhood? What do I know about that surrounding neighborhood in terms of things like the age of the population, the demographics of the population? If we're interested in environmental justice, for example, we'd like to know something about the historic socioeconomic status, racial makeup of that neighborhood, that community, and be able to relate that historically to cumulative exposures that that community has had from a whole variety of historical facility siting. And that's a far different kind of process, scientifically, from a regulatory point of view, than historically thinking about how do we reduce ozone overall for the entire population in the city of Baltimore. And it really requires that we take a different view, both of the, for example, facility siting process and the relationship between health and the location, plan, design, and implementation of various components of the built environment. So back to transportation. So historically, we sort of thought about transportation from the point of view of cumulative contribution to nitrogen oxides, photochemical smog, particulates, etc. But we really didn't think about that other than how many vehicle miles are traveled by in a transportation corridor, how many vehicles are on the road, what kinds of offsets are there if you cumulatively offset X number of vehicles in the whole urban area, what does that do to the particulate load, etc. Again, from the point of view of doing what a health impact assessment would do, you really have to focus more granularly than that. You have to look at the actual proposed corridor and think and plan for if we offset vehicles in this neighborhood. First of all, what are the pre-existing vulnerabilities of that neighborhood? What do we know about hazards and exposures in that neighborhood? And what does change in transit in that neighborhood and surrounding environs mean for the people in that neighborhood? So this is, again, it's a more detailed process. It's not very easy to do, and I think you can see from what Anna did that there are many, many challenges. And I have to point out, there are people from the Baltimore City Health Department and here in the audience, and one of the things that this requires is pretty detailed information, not just about the city's epidemiology and population, but you really have to know individual neighborhoods, and the kind of data that Anna showed there is not easy to find unless you have surveillance systems that allow you to focus geographically on small neighborhoods and be able to generate data for those neighborhoods. The other thing to say is that we're also thinking now more not just about the granularity of or the detail of pre-existing epidemiology, but also what are the health effects that we think about as being relevant to transportation choices, for example. So again, we've sort of traditionally thought about cardiorespiratory disease because it's the thing that people focused on most often. We have the longest history with heart disease, lung disease, asthma, et cetera, and particulates, photochemical smog, et cetera. But if you look at what the Europeans are doing, what we're doing in research centers, people are now focusing on issues of mental health, for example. There's some really interesting data that's come out of Europe and elsewhere looking at the relationship between noise and mortality, even things like traffic sirens and mortality. And so we're really getting a much more detailed picture about the relationship between the environment, not just environmental chemicals, which is sort of where our focus has been historically, but the environment writ large and health impacts. So a lot of these sort of secondary health effects not only are the result of exposures from chemicals, exogenous exposures, if you will, but also lifestyle and behavior. And so issues, we're looking much more at things like connectivity and walkability of neighborhoods as being predictors of physical activity. I have to say, if you look at this literature in detail, there are some extremes which point out that, for example, in New York City, with very good traffic, very good transit, mass transit, very good walkability, and really difficulty navigating in a car, there's very high physical activity, and so people tend to point to that as being an example of inferring that promoting physical connectivity of walkways, for example, and urban mass transit will lead to people walking more. That literature, if you look at it in detail, it works on the extremes of New York City, for example, versus very, very rural environments where people drive everywhere. But in the middle, the question about whether or not incremental changes in walkability lead to changes in physical activity is a hypothesis that has yet, I think, to be really demonstrated conclusively. So I think again, this is an area where there's a lot of data need and research need. The other thing that I think is helpful to think about is this issue of neighborhood level effects. And here, as I mentioned, the work that Tom Glass, Brian Schwartz, and others have done, and many others have really pointed out that it's not simply the exposure of that individual that's a predictor of disease, but you really have to look at the neighborhood and the place and understand more about that. So this whole context of socioeconomics, of the condition of the neighborhood, jobs, et cetera, and a lot of the factors that are wrapped up in environmental justice become very important here, because we are finding that these neighborhood level effects can play very, very important roles in terms of public health impact. So as I alluded to, we're really beginning to look at these more precise exposure-response relationships, both for individuals and populations. There's a lot of work to do here, both in terms of dosimetry and understanding the relationship between place, presence of an exposure, and individual dose and exposure. While we're beginning to get some kind of inkling of how that works, there is still a great deal of room for more knowledge. And I think that you're going to see in the next couple of years that interest in this field, driven by the need to think about how we build and plan and what its relationship is to health as we sort of broaden our conception of environment and health impact, we're going to see more data generated and more interest on the part of funders to kind of generate that kind of research activity. However, it is also important to point out that we are a little bit stuck to some extent on issues of physical activity, obesity, and social cohesion. Not that these are not important issues, these are very important issues, but they tend to come up over and over again. And I really think that one of the things that is missing in this discussion is a sort of a broader view of some of the other health impacts that don't get mentioned as often, but that are probably still important in terms of thinking about the relationship between place and health. So, and I know for people looking on a small screen in a small player on the web, this will look like white and dark. But I'll just point out here that this is a sort of a simplified model of the relationship between transportation of health. And if you think about transportation modality and whether or not people can easily access it, one of the things that Anna looked at, as well as baseline issues of access, social environment, health of the population, and then the direct effects of sort of environmental impact related to things like when you introduce a transit system, how do you change the direct kind of environmental picture of photochemical smog, et cetera. Usually these are relatively small effects. Even with a large project like the Red Line, if you looked at what the impact of changing traffic, vehicle miles traveled from the Red Line is going to be on issues of photochemical smog, particulates, et cetera, because so much of that environmental stress comes, and those environmental hazards are generated by vehicle traffic, but also by long-distance kinds of particulate generated, for example, by power generation in the Midwest. Even the introduction of a major transit system is not going to significantly, except in combination with many, many other changes, make a significant change in terms of ambient exposures or ambient concentrations of ozone, particulates, et cetera. So you end up with relatively small effects on environmental hazards, but if you then look at secondary effects like physical activity, and then things like noise, emissions, and injury, you begin to see that there are sort of three categories, or at least three categories of possible impact. One is the issue of physical activity. And this doesn't turn out necessarily to be a simple, if you build transit, there's more physical activity. As I said, that research is really fairly complex, and we really need more information about it. One of the issues, for example, is where you locate stops and how easy it is for people to get to may play a very significant role in terms of whether, for example, vulnerable populations, take, for example, the elderly, who may have issues with mobility. Well, how you place that system may play a large role in whether or not people are more likely or less likely to use transit and replace their cars. And so it's not a simple one-to-one. You build the transit system, suddenly everybody flocks to it. The design becomes very, very important. Similarly, if you look at environmental impact, I think one of the issues that Anna raised is this issue of greenscape or tree cover. If you make big changes to the environment, how do you affect greenscape? Well, you have to start looking at that and opportunities to leverage development to do that. They're not directly linked, but using the health impact assessment process, you can bring in some of these other factors to offset the kind of development that you're doing. One example, for example, is from San Francisco, when people did a health impact assessment involving a large-scale development in the Bay Area. One of the things they did was look at accessibility of grocery stores with fresh fruit and vegetables, where before the neighborhoods had not had much of that access, where this development was going to take place. And in fact, in the original proposal for the development, there was no direct relationship with grocery stores and access to fresh fruits and vegetables. So that through the health impact assessment process, the fix, if you will, that came up didn't actually relate to the development itself, but it was a mandate for, as part of that development, putting a grocery store so that it was accessible to people within a 6-mile radius of the development. So the health impact assessment process not only looks at direct health relationships and direct health impact, but also these kind of secondary benefits, very importantly. So let me just talk finally about a couple of challenges. And I've sort of mentioned several of these already. One is that these are fairly complicated. If you're going to do this rigorously, these are fairly complicated dose-response relationships, and there's a lot of stuff that we don't understand still about how, if you make changes prospectively in things like facilities, transportation, et cetera, how does that affect behavior? A lot of that is stuff that still needs to be worked out rigorously with good research as well as good demonstration projects on the ground. Second thing is that in general, most of the, or many of the kinds of health effects that we're looking at in the relationship to exposures involve relatively low attributable risk. So it's not like communicable disease where you can point to, yes, if we build sanitary housing, we will reduce deaths by 50%. That's an easy one. This is one where you're looking at incremental benefits to health over a long time period, and it can be difficult if you're looking at, if you're a builder and thinking about return on investment, and society looking at return on investment, to make that direct cost-benefit kind of link convincing, and that's a challenge. There are a couple of exceptions that I mentioned, asthma, for example, and we're knowing more about proximity of schools to roads and the relationship of asthma in kids to vehicle traffic nearby, but that's the exception rather than the rule in many cases. And this whole idea of secondary benefits is one that we really sort of are beginning to explore. So just in terms of closing, where we could see health impact assessment going, one question that I think is, in the 1970s, when we created the National Environmental Policy Act, we made environmental impact statements an integral part of development because we were concerned about the effect of development on the physical environment. So the question is, are we going to start thinking about health in the same way? And are we going to start making health impact a mandatory or at least a highly encouraged part of the planning and development process when we think about things like transportation systems? And the second linked question is, how are we going to improve the data and the basis on which we understand the relationship so that we can in fact use the best available information to do that planning? So with that, I'll close and I guess we can take questions.
At this point in the program, we do welcome questions, and we have a Q&A both for the live audience here as well for those watching online. And just a reminder, for those who are watching online, you can send in your emailed questions to our email address at MAPHTC, that stands for the Mid-Atlantic Public Health Training Center, at JHSPH, Johns Hopkins School of Public Health.edu. So why don't we go ahead and get started with any questions from people here that you might have for either Cliff or Anna. Yeah.
Left out crime, location of stations, and so forth, and I think it's important to assess the crime in neighborhoods, danger to people walking on the streets.
I think Anna actually can start with that because that was a question that she looked at was raised in the Red Line project.
Hi, yeah. Actually, a lot of people talked about crime, and we didn't directly address it. I agree with you that it's very important, and it's something that we're looking at through the community compact process as well. And actually, some other issues similar to that were already mentioned in the community compact, so we didn't necessarily feel the need to be completely redundant in the health impact assessment.
And I can just add, Dr. Dannenberg, that it's a very important question because the issue of public safety came up a lot when people were talking even about access to, and I recall from some of the discussions, when people were talking about access to the transit system, feeling safe in the context of access to the transit system was very, very important. It raises an interesting question because a lot of times when you engage with the community, you know, we as environmental health folks, environmental health researchers, professionals, practitioners, et cetera, have one sort of concept of what environmental health means when we go into a community. And oftentimes the community's picture of what environmental health is very, very different. And so issues like that, for example, of the so-called crime and grime issues, there was a health impact assessment done in a community in Florida where exactly that kind of thing happened. The environmental health folks went in from the Florida Health Department and were concerned about issues like sanitation, clean water, et cetera. The community was very concerned about streetlights because without streetlights they didn't feel safe going to the grocery store, and that for them was an environmental health issue. So it's a very, very good point.
Can you talk a little bit about how you think this whole movement of health impact assessment might coincide with looking at integrating prevention into healthcare reform, and how the whole movement of healthcare reform might turn to health impact assessment as a way of improving health and reducing costs?
I can start. Health impact assessment, I think, is still in its infancy, and it's the set of methodologies that I described to you, the 6 steps, are kind of the informal code for doing the health impact assessment. I think it's a really good model for bringing together a lot of information and putting it in one place and then looking at the prospective impacts. So I think in that sense it has a role for prevention, looking at how can we, before a project or a policy is implemented or even any kind of changes is taken place, how can we look at how this is impacting health? I wasn't going to say directly, but explicitly looking at different impacts on health.
Yeah, and I guess if you look at where health impact assessment has been used both in Europe and here in the United States, it's really been used primarily in areas of planning, development, et cetera. Because a lot of healthcare reform is tied up in issues of healthcare finance as well, and accessibility and access to care, those issues are probably not primarily related to health impact assessment. Where I think the issue of prevention, though, is more directly linked in the sense that as we begin to think about prevention writ large, you do have to start thinking about what is the impact of how we live, how we build, how we do things and organize as a society. That's absolutely critical to issues of prevention. And we know from all the research that's out there that lifestyle, which is directly related to how we live, which is directly related to how we build and how we organize our physical environment. I think that's an absolutely critical issue and one where there's a significant contribution to be made. The challenge, again, is going to be providing good data, sound research, and and building it into the process. And that, I think, is a challenge, which is both a political challenge as well as a sort of a scientific challenge.
Anna, you mentioned neighborhood cohesion as one of the impacts of the red line that you're looking at, and I wanted to hear a little more about how that's to be measured and whether there are models elsewhere that you're looking at where they've measured neighborhood cohesion, or whether that's something that you've had to develop for this study here.
That's a good question. There's been other studies that look at how often people speak to their neighbors, what the crime levels are in neighborhoods. We didn't actually, I mostly was looking at some scientific literature on that. I wasn't actually looking at data from Baltimore that measured neighborhood cohesion. And then how would we measure that as we go forth? I don't know if we've exactly thought about that component of it, to be honest. But do you have any?
And I think, you know, it raises the issue of social capital and the whole issue of and this gets back to the issue of whether we as environmental health folks, and I include myself in that, but this is an area that's sort of a multidisciplinary area by definition, and the sociological literature actually has a lot of social capital indicators, tools for measurement. I think one of the challenges for us is that, and I'm certainly not an expert on social capital or its measurement, and there are folks here who are, but I do think that one of the things that we're trying to do in terms of thinking about environmental health surveillance, this sort of goes to your question, is right now we really don't collect data systematically on those indicators, certainly not at a state level and not necessarily even at a community level. One of the things that I've been working on at the state is something called environmental public health tracking, which is basically trying to integrate environmental data and health data. And one of the things that we've been talking a lot about is the fact that you really can't just talk about environmental data, exposure data, health data, outcome data, without including social data, social demographic data, socioeconomic data as part of that if you're really going to be able to use ongoing existing surveillance systems that are already in place in many cases to integrate those and be able to answer the kind of question you're asking. But I think more directly, one of the challenges is that, particularly with health data, but even with some of the social data, getting it down to a fine enough level in terms of geography to be able to use it usefully. There are issues of confidentiality and privacy and other kinds of issues, as well as are we collecting it at all, that are a challenge.
I think one of the other things is that we're looking at some of the big picture potential impacts of the red line, and not just things that will happen immediately and directly, but as Cliff was talking about in his presentation, some of the more indirect impacts that we wouldn't necessarily be able to evaluate and say this is absolutely because of the red line, or this is absolutely because we located a station at this block that now the neighborhood seems to have a little bit more social capital, a little bit more people on the street necessarily. So I think it's one of those things that is very hard to measure.
Just in relation to the original light rail line that goes north-south, it sounds like this is a very different process taking place with this new east-west than the original one, which it seems like the original line was really meant or sort of designed to feed a bunch of stadium parking lots and swing gates. And it sounds like this has got a lot more thought process involved. Is the 14-mile, is that a hard limit? Is it possible they'll ever extend? Because, I mean, with Timonium, they actually went further to Hunt Valley, and I'm not sure exactly when that planning process took place, but it does sound like this is quite different from the standpoint of the original line, and I'm wondering if you looked at communities along that original line for some of the actual either anticipated impacts or the non-anticipated impacts.
Yeah, I think you're very right. The original light rail line that currently exists, the north-south blue line, is what it's the color code for it. It was a really top-down project, and this project is much more of a the city's taken initiative to be involved from the beginning. And yes, the 14 miles is what we're looking at the moment. There's certainly plans in the further future to think about extending that. They wouldn't be limited by the route that we have now. And then in terms of looking at the current light rail line, I think that it's such a different neighborhood and such a different context for this east-west line that would be difficult. I think it would be difficult to look at some of the current neighborhoods along the route and transpose them into the center city that the red line goes through.
Well, I'm just thinking about, from the perspective of noise and crime, I would think that you get some pretty quick feedback.
Yeah, absolutely, right. So there has been some crime along the light rail route that exists now, and so when we're looking at the design of the stations, and this wasn't particular to the health impact assessment, but certainly through the community compact process, looking at security and safety and accessibility as being really right now the light rail line is really designed about driving to it and not necessarily about involving the neighborhoods and making sure that the stations are an integral component of neighborhoods, which is what we want to see happen with the red line.
The cynic in me says we'll do a lot of planning and a lot of bottom-up stuff, but then one day somebody's going to pull the trigger on making it happen and paying the money, and it's going to be top-down. And I always worry about a lot of these, and my question is, there's got to be some accountability or some power behind the accountability, not just necessarily citizens rising up, but some type of accountability that says, like, the environmental impact assessments are built in the code. Health impact assessments are not. I think everything you're saying makes complete sense, but I'm wondering how one puts teeth behind it until there's something in the code that says the health impact assessments are necessary and something that needs to be responded to. Until that happens, is this something that we go through as a public health exercise, or is it as an interdisciplinary exercise? But when the person who pulls the trigger on making this happen makes a decision, because the money comes from Washington on Tuesday and they say spend it by Wednesday, does it go out the window? Because that's actually how appropriations work, rather than this long process, as if Pew gave us the money or somebody who allowed for that kind of sort of contemplative, slow process. So how do you safeguard against that, or how do you?
Well, I have two comments to that. One of them is that I think the Baltimore Red Line HIA is somewhat unique in that it was couched within the community compact process, which had already been strongly involved the state, and the state has signed on to it, and I think there would be some public shaming if the state actually didn't hold up some end of their bargain on that. And then the other aspect of that is that the New Starts funding, which is from the Federal Transit Administration, which the Red Line project this MTA is currently applying for to build the Red Line, actually has some significant components of community involvement requirements. So I think that hopefully, I'm hearing you, and I think it is a concern. It is a reality of the funding process. But I think hopefully the fact that if the federal government gives the funding, it will have the caveat that we see that you've done this and we would like to see you continue with this. So.
Let me just sort of make a global comment about that, because I think it's obviously a very important question, and I alluded to it when I was talking earlier. If you look at where health impact assessment has been used in this country, it is primarily in the West, some in the Midwest, and relatively little here on the East Coast. Part of that is because there's more building and development out there, bigger spaces, more opportunity to look at large-scale projects, but there is, I think, this is an evolution, and I think we are sort of at the beginning stage of inculcating in both the planning community and in the development community and in legislators and the policy community the idea that we have the wherewithal to be able to do this at all. And so I think, this is going to be an evolution in which we're going to have to demonstrate that it works. And there is some of that already out there, but there are going to be these little pilots that happen throughout. It'll be very important to have successful demonstrations. One of the comments that I got during one of the Red Line big mass meetings was some concern on the part of the development community. They looked at this the way they look at environmental impact statements, which is this is yet another obstacle in which it's just going to go on and on and on, and at the end of the day, it's just an opportunity to provide roadblocks. And I think for those whose political agenda is to sort of bring health into the development and planning process more concretely, it's going to be very important for us to speak in the language of development and planning. It's not simply a question of the planning community learning to talk our language. We have to be able to talk about return on investment. We have to be able to talk about life cycle costing. We have to be able to talk about the other constraints that developers and planners work under, like other parts of code, and figure out how this integrates with that. So it's not simply a question of health setting an agenda for the planning process. It's really a question of becoming a player. And that, frankly, requires more movement on our part as health people than it does on the planning community's part, because they got the money. We don't got the money, to be elegant about it. Because health is not part of the process, we are going to have to insert ourselves into the process and go to them rather than having the mountain come to us.
Any other questions? We do have, could I have the mic? We do have a question from our online audience. What would happen if we do not consider the environmental impact of, say, the red line? What would be the excess morbidity, or is there a way to measure that at all?
You want to start?
Well, I don't know if there's a way to necessarily measure the excess morbidity of not doing the red line, but I think that goes back to our initial premise of it's an important project to do and that it will have positive health impacts on the city as a whole and specifically the neighborhoods that it goes through.
Yeah, and I think this very much goes to the comments that we were making earlier, which is that, you know, if you look at what at actual dose-response relationships, for example, and then try to figure out, I mean, here's an exercise if you really want to drive your brain crazy, which is try to actually predict what the offset is in vehicle miles traveled from vehicles taken off the road by the red line, then looking at changes in the ozone and particulate concentration in the city in specific neighborhoods, which requires fairly sophisticated modeling of the local traffic, local exhaust, changes in local microenvironments, understand enough about the health of that baseline community to then say, well, given this micro change in this microenvironment, what's the incremental change in health status going to be for this population? And very quickly what you'll find out is that, in fact, we really don't have the tools to be able to do that. So I don't think we're at the point where we can actually predict changes in morbidity and mortality with this one project. But as Anna said, that's really, I don't think that the intent of the process. The intent of the process is to engage with the local community, thinking about local conditions, thinking about how we can begin to change the pattern of thinking about development and include health writ large as part of that process. And many of the benefits may not be in mortality and morbidity. They may be in things like social capital. And they may be very much in terms of things like greenscape and tree cover, which, if you think about the heat island effect and global climate change, become very important factors. But it's not that we're going to be able to measure those directly for this one project and see a change in overall mortality and morbidity. Dr. Baker?
Welcome back, welcome back. Glad to have you here, even though temporarily. One thing that's interesting and could easily be looked at is the number of falls on transportation, the number of people hit getting off. Transportation, there was a Nigerian student, for Lord's sakes, who came here and tried to do something about crossing Wolf Street, very dangerous thing. City, not interested. and your planners, your wonderful planners who could blend together the two systems of mass transport. We've got an uphill job. One, to get decent planning overall. I mean, Jesus, to have two systems that don't meet, and you have to go through, I don't know, about 3 blocks to get from one to the other, which you don't want to do late at night in that area. What about looking, I came in a little late, so I didn't hear about the importance of injury.
And it's a very good point, and Anna can comment specifically about injury prevention and injury statistics. She already made some comments about that in her presentation, but I do think, again, we sort of have this traditional view of environmental impacts being primarily these sort of chronic, long-term chemical hazards, et cetera. But as you point out, and the Center for Injury Prevention has done a lot of work on this, transportation is associated with injuries, both from the point of view of not having transportation, having to do alternative kinds of transportation, and injuries associated with the transportation modalities themselves. And so part of the health impact assessment process is to look holistically, not just at chronic environmental exposures, but also those acute exposures. And they very, very, very much came up in the discussion of the red line.
Yeah, and actually I think this goes back to what Cliff said earlier about looking at the really fine detailed level that projects or where a project is put in, and something that the health impact assessment was trying to get to by saying we can put in a transit line and we could maybe see some benefits, but it really comes down to what are the details that actually encourage safe street crossing and, well, encourage pedestrian activity, but then encourage safety and promote safety when people are crossing the street or when people are riding their bicycle in any area near this particular project. So those are the kinds of considerations that we're looking at in detail and implementing now, exactly, very specifically what they will look like. Because if there's not a ramp at a certain location, then people won't have access to it, to a station, for example. And if there's not a crosswalk, people might cross the street anyway, which we see a lot in Baltimore City. And the repercussions of that are pretty significant.
Was there any investigation into looking at, for instance, emergency shelter locations and the stops along that line?
We're actually in the process of doing some mapping now to look at where some of our significant elderly populations are, for example, potentially emergency shelters as well, to see exactly where we can maximize accessibility by how we place the stops. It's a good idea.
We do have another online question, and this one comes to us from Boston, Massachusetts. I've heard arguments that human health impact assessment should be wrapped into the environmental impact assessment process. What's the benefit of conducting a separate impact assessment process for health? Regarding federal projects, for example, the air quality, water quality, socioeconomic impacts sections of the NEPA documents could easily incorporate health concerns and often do.
And I think it's a very good point. Actually, it is the context in which this particular project was done. So this, and Anna can talk about this. When it was started, it was actually within the context of the draft environmental impact statement. I think the answer is, just as we think more and more about environment and health linked, it is in fact, I think, very reasonable and a good idea to think about these as linked, because the environmental impact statement, the assessment of the environment and environmental changes, is, as we've discussed, intimately related to health impacts. That said, the health, part of the question has to do with the way NEPA, the National Environmental Policy Act, and environmental impact statements are done. And they are somewhat formulaic. They tend to be very large, cumbersome documents sometimes. And one of the important parts of health impact assessment is not so much the framework in which they're done, which Anna talked about, but this idea of community engagement and engagement with the local community and the affected community becomes very, very critical. So it's not, I don't think, I think it's perfectly reasonable to think about the environmental impact statement as, or the environmental impact assessment process as being part of this, or this being a part of that. But in the process, the environmental impact assessment process itself ought probably to change, if we're going to think about this more rationally, to include engagement with local communities, so that it's not simply that the health impact assessment is an add-on to the environmental impact statement. More appropriately, we really ought to think about amending the National Environmental Policy Act, or putting it within a larger context, which is we ought to think about a National Environmental and Health Policy Act. And then you would sort of have a cumulative look at both environment and health together. It's a modest legislative proposal for Washington.
Anything else? Any other questions? Okay, I want to thank once again Anna Ricklin and Cliff Mitchell for joining us today. It was a fantastic presentation.